Okay, this afternoon we're going to have a discussion about drug pricing and benefit management. And it's going to be moderated by our Life Accident and Health Director, Michael Wilkey. We've got representatives from PhRMA, Cigna, and MedImpact that Michael is going to introduce to you and start the panel discussion.
Thank you, Commissioner. Oh, excuse me. Thank you, Commissioner. I'm going to have my back turned most of the time, and we had a logistical challenge here in getting 4 chairs and the microphones from which to be able to be set up. So please don't take it personally. This is not the next presidential debate. This is really going to be a forum for
better candidates.
Everybody. I think they all like each other, so this is a positive sign as we move to this session. With us today, we have 3 distinguished representatives of their respective industries. We have Saumil, who's the Senior Director in Policy and Research at PhRMA. Welcome. We also have Chris Bradbury, who's the Integrated Clinical Solutions and Specialty Pharmacy Leader. Sorry, it's a long one. For Cigna Pharmacy Management. And we have Tim Novak, who's the Senior Regional Sales Executive for MedImpact Health System. What I'd like to do right now is give each of these gentlemen the opportunity to kind of say a little bit about themselves, as well as the organization which they represent, and then we'll go into some questions. Please, and we're going to start with you. Please, Saumil.
Oh, hi. My name is Saumil Pandya. I just want to thank you all for having us here today. It's a pleasure to join you here. I don't know, my story is sort of like kind of a winding background. Started out, I did my master's degree at Johns Hopkins in Health, Finance, and Management at the School of Public Health. I actually worked for Cigna, my first job out of grad school in Bloomfield, Connecticut. My whole career has been on the business side except for the last 15 months. So worked in medical economics and finance roles at Cigna and Coventry Healthcare as the 2 insurers. And I also, along with some consulting roles, worked in there as well. And I worked at AstraZeneca Pharmaceuticals for about almost 5 to 6 years in pricing and contracting strategy. So I actually priced drugs for a living for a period of time. So it's not as crazy black boxes as you think. Honestly, it's not that sinister, right? And then my last job before coming to PhRMA was I worked at Evergreen Health Co-op. It's one of the co-ops that was founded through the Affordable Care Act. It's a Maryland co-op, still going, it's still in business. And I was a vice president of medical economics there. And I've been at PhRMA for the last 15 months in policy and research. It's my first policy gig. Everything else has been on the business side up until this point.
Thank you. Welcome. Yeah. Chris.
Good afternoon. Thrilled to be here. Cigna, it's especially appropriate for Cigna to be here. We're both a big employer in the state. We service both as a health plan, a pharmacy benefit manager. We're a care provider through a variety of our solutions. We're also one of the nation's largest specialty pharmacies. So we play a variety of roles, and thrilled to be able to participate in the conversation today. A couple just quick points as backdrop. Loved the conversation earlier. We are seeing some real concerns around the rising affordability of prescription drugs. Look forward to the conversation. Look forward to actually focusing a little bit of the conversation, because where markets work really well, and I'll say there's competition, there's very good affordability. Where there are parts of the market where there isn't competition, right, are some real challenges, both specialty drugs, but also in some key categories. A couple other quick points with it. One, as we go forward, part of our approach is hopefully to engineer out, quite frankly, a lot of the need for drugs, right? And that's very interesting coming from somebody that runs a pharmacy benefit manager or a specialty pharmacy. I mean, the reality is, through better lifestyle behaviors and some of the things that we talked about earlier, many of the prescription drugs that are being used would not be needed. And that's part of our role, and what we strive to do better and better is to, quite frankly, eliminate the need for many of these things. And nothing would make us feel better as a company in order to do that, because it achieves a variety of goals. Second with it, we'll be touching on, hopefully through the dialogue, the importance of aligning reimbursement more based on value, right? And well, what do we mean by value? And as part of our approach and our strategy is to do that throughout the healthcare system, with providers, with hospitals, with the health plan, with the PBM, with the specialty pharmacy, with other care providers in that regard. And then although we're also talking a lot about prescription drugs and the affordability challenges with it, I think at the same time it's very important we don't take our eye off of helping to take some bold actions to solve some other health crises that are occurring. the example with Cigna, in our efforts to eliminate a lot of the inappropriate opioid use, in our commitment to both the states and the federal government in order to take a quarter of the opioid use out of the population over the next 3 years. So thank you for having us here, and look forward to the dialogue that we're going to have.
Pleasure to have you. Thank you. Tim.
Good afternoon. I'm Tim Novak, and I echo the gratitude for being here. It was very interesting conversations this morning, and teed things up very nicely. I mean, the themes that run through all of it are very familiar, of course. My background has been in the PBM space for about the last 25 years, primarily on the business development side. Worked with a major PBM for about 19 or 20 years, and been at MedImpact now for the last 5 or 6 years, and did some consulting work in between. MedImpact is the largest privately held PBM in the industry, and has kind of a unique business model that I won't try to sell to you today. That's for another day. But my representation to the panel and discussion will be from the plan sponsor's perspective. That's my client. That's who I know best. That's who I've worked with over the years, and I look forward to a great dialogue.
Welcome. My first opportunity or question is going to be for you, Saumil. You know, we've heard a lot this morning. We talked about the cost of pharmacy benefits within the overall, claims spend. We've talked about what is the actual trend of about 8.7%, but projected trends of 18, 19% across the board. It is kind of a mystique, I think, for most people. Can you take a few minutes and kind of peel back this onion on how manufacturers price their particular, drug products?
Sure. Be happy to. To just put a couple of things in context first. Some of the data points that I will be referencing, it's all government data. So every year, CMS puts out what they call National Health Expenditures Report, which you guys probably are familiar with, which talks about an estimation of net spending on all different healthcare categories, including prescription drugs. Now, the National Health Expenditures Report only captures retail, so drugs that are paid for through dispensed through retail pharmacies. So we did some additional work to try to capture the hospital-administered drugs with a health economics firm called the Altarum Institute, and all physician-administered drugs. So the total is, like they said, that across all payers, and the NHG data, the National Health Expenditures, say the retail drugs account for 10% of total healthcare spending in the United States. The non-retail drugs, when you add that on, is an additional 4%. So that's 14% of total healthcare spending trend. Hospital spending, on comparison, is about 3 times the amount we're talking about here. So that's when you look at hospitals together, which I saw in a couple of reports earlier, where you're separating out hospital inpatient, hospital outpatient. That's when they separate out ER care. Like it's hospital care. So when you're looking at that entire bucket, what the federal government believes, government actuaries believe, that the trend going forward, outside of the spike year in 2014, coming back down in 15, is that the trend for prescription drug growth will be between 6 and 8% going out through 2025. That's according to the federal government across all payers. Now, it's going to be a little bit higher in the commercial space, as our colleagues up here would talk to, because the population is a little bit different. The way you're talking about this percentage is you have the drug spend as a numerator, and you have total healthcare spending as a denominator. Well, if it's a working population, people are younger and healthier, so they don't have as many hospitalizations or doctor's visits. So the denominator is a little bit smaller. So in the NHE, according to the NHE information, the retail drug spend for the commercial population is only 13% of healthcare spending. And that trend is between 5 and 8% projected to go out through 2025. So it goes up a little bit from 10 to 13%, and then you add on the non-retail, it could probably go up to about 17, 18%. I would believe that completely for overall spending, not trend. And the trend is still between 6 and 8%, according to, which is in line with overall healthcare spending trend. So now you asked me about, I don't want to filibuster. Ask me about how drugs are priced, and there's a number of factors that go into this. It's not just R&D costs, which is a lot of times referred to in the media. So people say, well, look, this is what your R&D costs were, this is what your marketing budget is, this is what your SG&A is, your salaries and general administrative expenses are, then we're going to add on a little bit of profit, and that's what the drug should cost. That's not the model. It's not a cost-plus model. When you're looking to price a drug, is what is the cost of treating the disease right now absent the drug? What are the medical interventions that are out there in the marketplace? How are drugs, what is the cost of treating that particular illness? So when you go to a payer and you're trying to get a drug approved, and you're trying to go into contract negotiations with them, if the cost of treating the disease is, say, hypothetically, just making up numbers, say $40,000, and you want to charge $100,000 for the drug, but you're not and the outcome of the medical intervention and the pharmacy intervention is the same, there's no way the payer goes for that. So you have to provide value to the payer when you're doing that particular contract negotiation, in that the cost of the drug and the value that it brings in medical cost offsets cannot exceed the total overall spending that you're doing for that particular intervention, absent the existence of the medicine. So you're looking at factors of what the spending is for without the drug, what do you need in the pipeline to be able to do the ongoing research for future drug development. This is an industry, it's a high risk industry. Only 12% of drugs that go into clinical trials actually make it to market. So I'm a big baseball fan. Like, you look at this, you say you failed 7 out of 10 times in baseball, you're in the Hall of Fame. Here you're failing 9 out of 10 times. All right, so you're failing 9 out of 10 times to get drugs on the market, and you want to keep having the money and investors interested in funding you, so that you will continue to do additional R&D to find future cures, and you want to have that continued impetus. So what's going on in the marketplace, what their financial needs of the organization are, and how you're going to how you're going to impact the overall budget. I hope that somewhat answers that question.
That's good. Thank you very much. You've heard a little bit about how the prices are set. You've heard the discussions from this morning. I'll turn this next question to both you, Chris, and to you, Tim. This all gets translated now to some formulas of average wholesale price. You get it in MAP pricing. You get it usual and customary, and you have the high costs. And you're dealing with your clients, whether they be insurance companies or whether they be large employers that are out there. How do you translate this? I mean, how do you take this cost structure to an employer, say, for example, who's spending maybe $10 million a year for their employees or their employee cost sharing? How do you send that message?
Yeah, so great question. I mean, a few things that just at the stage. When we talk about drug pricing and protecting the customer or the member, I think we can all agree we need to protect the member and to ensure that they have access to comprehensive and affordable prescription drug coverage. I think that's where we all agree. The challenge with that, in many categories, is the fundamental cost of the drug that is driving those pressures. And I'll put it into 2 buckets. Those places where there is a highly competitive market, and a competitive market being based upon there are multiple alternative therapies, right, where we can create competition. There's the ability for an individual to choose and transition to different medications, creates an environment to garner major price concessions from the pharmaceutical manufacturers, which then we pass on to our clients and to our customers. So as we sit down with plan sponsors, it usually starts with, what's your benefit strategy? All right? What are you trying to accomplish? What are the things that are most important to your benefits? And then from there, present a series of options for them that help them understand the choices that need to be made. Because whether you're an employer, whether you're a government, whether you're a union, right, there usually isn't an infinite amount of dollars. And so it comes down to how we can share data and insights to help make the best choices around the dollars that they have, and that there are real choices. Part of that, as it relates to whether it's formulary design, network design, utilization management, is how to first get to the things that will drive better health, that are the right things to do for all of us, and that will also lower cost. The second is getting to, well, what's the net cost difference of all of these actions? Because a lot of these things start with a list price, right? And there's a difference between a list price and the net price. And so all of our conversations with our clients are really down, what's the net cost with it, to help drive the best decisions based upon their priorities. And that's a very complex discussion. The good news is when you have that, it creates great alignment with what they're contracting with us, what they're asking us to do, and then what we do within the delivery chain of aligning those other participants in the process to deliver both the care and the affordability that's needed.
Tim?
Yeah, I don't disagree with any of that. Certainly endorse it completely. The only thing that occurs to me in this area is going back to some of the things that Sarah touched on. Those are the conversations that we're having with our clients now, is not what am I spending, what's the value for what I'm spending that dollar for. And to Chris's point, it's, you know, it's finite resources, and it's managing those finite resources that the PBMs try to help the client with. Do they understand how the drug gets priced? No. That's why there's a whole consulting industry that's growing up around the PBM space to help the end payer understand those layers of pricing and that sort of thing. But the holy grail in this business, as in any area of healthcare, is what's the value? What am I getting for that dollar? Because I've been doing this for a long time, and I've never met with a plan sponsor who didn't want to do exactly what Chris pointed out at the beginning, and that is make sure that they were delivering a quality benefit for their employees, and that it was a benefit and value and perceived value by the employee as well.
As you work with various insurers or large clients in developing the formularies, a lot of this is price. You know, we heard a little bit this morning about the concern about actually what are the clinical outcomes, what are the alternatives that are available to yield the same outcome. Does that get in the way of your ability from which to have those discussions with your clients, and how does that work?
There's so many options that are available to plan sponsors now. They can pick from a menu of highly restrictive to very open formularies, networks, different pricing structures, et cetera, and so on. So the conversation always does begin, what is the objective of the plan sponsor? And what are their goals for it? I mean, there's always a cost element to it. I mean, every benefit manager I ever met with, starts the conversation by saying we need to reduce our cost by 10%. Or some number, but ultimately they've got so many options. We have to understand their strategy before we can even make recommendations.
But does this really come down to price in many instances of drug A versus drug B, and if in fact the net cost is a little bit lower, but the clinical outcome you're not sure of?
No, the clinical piece is always first and foremost. Absolutely, we're not going to put a drug on a formulary just for price perspective at all. That side of the equation isn't even addressed until the quality measures are factored in.
Good.
Yeah. If I could add on that,
Please.
I mean, just on formularies, how formularies are developed, and I'll give the Cigna experience with it. It is a data-driven, clinical-first approach, right? There are certain drug classes that we're required to offer, and we should offer in our formularies. There's a clinical evaluation with a group of independent P&T members. It is truly independent in that regard, and that really sets the framework for classes, the types of drugs. Are drugs superior in a class, neutral, right, or inferior? Where the formulary then takes on some additional life, or in those categories, when there are a group of products that are similar. Right? I don't want to say completely interchangeable for all people, but in essence, they treat the same thing, and for the overwhelming majority of individuals, they will do the job. And that's where in the formulary, in the final decision, where cost comes in, right? Because we know it's important to cover 2, 3, 4, 5 products in that category, whatever the P&T thinks is appropriate in that regard, and that's where we work with the pharmaceutical manufacturers and bring competition. An intense competition, right? Because what I would say with competition works. It drives better pricing, it drives better innovation, right? And that's what we strive to create. One of the shifts that has occurred and that we're spending more and more time on is it's not just for comparable products to get the best unit price, but it's also to align the incentives with the manufacturers on the real world outcomes of their products. Right? I mean, we've started to think, and we're starting to push very, very aggressively, what are the things that we buy, either as a company or as an individual, that may cost $10,000, $50,000, $500,000 a year, right? And if it doesn't work, you're still on the hook for the whole price. So another component that we're driving forward is how to better align, whether you call it value-based contracts or outcomes-based contract, to create real skin in the game. It also compels us and others in the industry, and Sarah was talking about this earlier, to invest in finding out what is really working in the real world, right? Controlled trials are great, but they're controlled trials. And so we're investing heavily and hepatitis C was an example, a lot of other cardiovascular areas, of understanding, not just having these outcomes-based agreements, but then tracking with real-world data how things are performing. A, to hold manufacturers accountable to the commitments that they've made through their trials. B, if they don't work, how to align, in essence, additional discounts that benefit our clients and our customers. But I'd say the third part, which is equally as powerful and important, is to advance the practice of medicine in the U.S. healthcare system, of what's working on what population, maybe what's working on other populations. And that is a powerful, powerful mechanism. It's one of the things that we're trying to drive more alignment, not just within our company, but quite frankly, across the whole U.S. healthcare system.
The only variable I'd put on there that we look at in the commercial markets, and I'm sure you do too, is when there are those similar products, we'll use that terminology, before they get formulary placement or before we recommend a given formulary to an employer, we look at member disruption too. If we were converting one drug to another for formulary placement, we'd look at how much of the members are impacted, how many of the members are impacted, and then the client makes a decision based on the economics of that and the pain versus gain.
So much has been said about, clinical trials and the outcomes associated with those trials. And some inferences were made as far as, who can release what information, the role of the FDA, other things. Saumil, what's the position of industry, the pharma industry, relative to the releasing of clinical trials? Is it supportive of transparency along these lines?
That I don't know if we have an official position as of yet, but I'm saying is I don't believe that we released the clinical trial data to the FDA. Now, at that point in time, so we are being transparent with the FDA. It's a very rigorous process. It takes over 10 years for a drug to get through that entire process, oftentimes. So that transparency, from that perspective, we have submitted. One of the things I was talking to you about earlier, and that was one question I actually had for Dr. Abramson earlier, is where's the comparable transparency required regarding evidence for, like, say, a new surgical procedure or a new medical procedure? I mean, the hospital spend, if it's 3 times as much as prescription drug spend. If I'm a hospital system, and I want to come up with a new surgical procedure for which I will demand a pretty high level of reimbursement for, where's that rigor? Where's the 10-year process to go through and submit all kinds of clinical information and trial data, and to be able to say, no, this is really worth the money. This procedure is going to be helpful to patients and work for them. So I think our industry is fairly transparent. We're willing to go further, and we're having active discussions on that front right now as to how much further and what we will be willing to do. But I think that from a clinical, I think we're submitting a tremendous amount of information to the FDA. Who's going to decide whether or not a drug is actually approved and safe and efficacious to be used in this country?
You mentioned that you're having discussions on it. Let me ask you this. What's the danger of releasing the clinical information and being totally transparent? Why is that a hindrance?
I mean, I'll be honest, this is not an area that I primarily work on, but I can give you what my viewpoint of that is that these are companies who are looking at different trials. That information can be misinterpreted. It can be very technical, and putting it out in the public domain in that regard may not be particularly helpful. Yes, someone else earlier has stated that even like when this stuff is put out, not even many of the even scientists or people who are reading it really fully understand what each of those and what the elements are, what they actually mean within that clinical trial information. So you're taking information, you're showing the FDA what the efficacy and value of that medicine is, and to go on to the point that you had just made before, even if a drug comes out and is approved by the FDA and say it's not necessarily clinically superior to a product that's on the market, you can call it, that drug adds to the competition that's in the marketplace. So that drug will be competing against another product that's on there, which PBMs and payers will use to drive higher rebates, to be able to lower net price, and to make it to lower overall cost in the marketplace that is there.
I mean, if I could add, I think there are several things that our governments could do to help. More transparency on the clinical trial data, right? There is a way to bring more transparency and protect the proprietary and confidential information that manufacturers have, right? There is a middle ground that we believe that's there, and I do think it would help. I know speaking on behalf of a health plan and a PBM and a specialty pharmacy that's involved in care, that would help us, right? Help us make better decisions around certain things. The other, how do we advance the speed to market, particularly to new generic drugs,
Yes.
right? That's a challenge. How do we get through and have a pathway for biosimilar interchangeability, right? That will help a ton in many instances. How do we help through and fund some other targeted research in some key areas? Because the drug pricing problem, right, is not in every category. There are a handful of categories that are driving the lion's share of the problem, and some additional research there. There's a very interesting idea around giving the NIH or the FDA the ability to at least comment on should there be a third arm in the clinical trial, right? Because part of what we're trying to do is how to best use all of our healthcare dollars. And they really are all of our dollars in that regard. Because there are some wonderful innovations that are coming, that have come, in the next 10 years are going to be remarkable. We've got to figure out how to create headroom, if you will, right? To take advantage of all the places where there's waste, or there are more cost-effective therapies, or just simply more effective therapies as well, to create that headroom to fund, if you will, these wonderful medications that are coming. So there's a real opportunity for collaboration. I mean, we've spent a lot of time in DC, a lot of time in other places, and what I would say is we probably agree on 80 to 90% of stuff, right? There might be 10, 20%, there are differences of opinion, and I think there is a wonderful opportunity to advance on the 80 to 90%, right? And then that remaining 5, 10, 15, 20%, we can figure out. But let's at least take advantage of that 80 to 90%. And I think, you know, through these types of dialogues and other dialogues is how do we focus attention on those therapeutic categories or areas that really are driving a lot of the trend growth. And I'll just share a couple of them. The inflammatory category for specialty drugs, right? It's the number one category in terms of our commercial book of business. And that it's growing at a rate that if it continues to go is simply unsustainable. Oncology medications, they're coming down the pipeline. Wonderful breakthroughs. Wonderful breakthroughs. What we're seeing is new drugs come to market faster with less evidence, right, that are offering up some wonderful cures. A large chunk of those drugs that are coming to market are not meeting quantifiable and measurable improvements, right, over existing therapies. Not saying that on all of them, but there's a large chunk, right, and the healthcare system is having to absorb those costs. Multiple sclerosis, right, and I can't wait to read the paper that's coming out. It's a wonderful, wonderful category. It does wonderful things. If you look at the average cost of therapy for an individual with MS over the last 10 years, right, the costs have doubled, tripled, quadrupled. I think it's like 5x. Have the outcomes gotten truly 5 times better during that time frame? The answer is no. So I think a lot of this is also how do we focus the dialogue in those very, very specific areas that are causing the problems, because many of the areas aren't where the free market system in competition is working, and it's the subset that really needs the attention. We can't do a broad brush across everything.
Okay. May I? A couple of questions I have, well, comments that I'd have. No insurer pays for one class of drugs, RA drugs, MS drugs. The relative prevalence of these illnesses is small considered the overall population of this country. 80% of healthcare spending is on chronic disease in this country. So things like diabetes, hypertension, dyslipidemia, CHF. Like, these are more chronic type conditions. So when you're talking about particular drugs that are on the market, and even if a new drug again comes along that is not necessarily what you would consider clinically superior, PBMs and health plans will pit that drug off the one that's already in the market to try to drive a better overall net price. The problem in this whole model that we talked about is we talked about list prices and net prices. List prices are like sticker prices on a car. They're the starting point for negotiation. Most people don't end up having to pay them. But what's occurring in the marketplace is that patients are being exposed greater and greater to that list price due to benefit design changes that are occurring. And that's where the pain is coming in. The real, genuine pain for patients is coming in is, how do I afford the medication? And you look at the medication, is it because of the cost, the list price of the medication nobody ends up paying? The fact that the net price, the rebates and discounts that manufacturers provide to PBMs and payers don't necessarily get passed on to patients at the point of sale? When you go to the pharmacy or you have a co-insurance, just say to give you an example, you have a $2,000 deductible, and you have a drug that costs $250 net list price per month. You go to your deductible, you have to pay the full $250 when you go to the pharmacy. Say the manufacturer is giving a 20% rebate to the payer, to the PBM. That's $50, 20% of $250. In that scenario, the patient is paid $250, the PBM is paid nothing, and they walk away, and the PBM walks away with $50. And that scenario repeats itself again and again and again. So you have higher benefit design changes, which are resulting in higher deductibles that patients are being exposed to, first dollar deductibles, higher co-insurance that's based off of the list price of the drug, despite the fact that they are getting that the payer is getting a rebate on that drug. So these areas are where you're seeing that overall trend, and the narrow therapeutic areas that we are talking about represent a very small percentage of the overall spend that the health plan is incurring. And when we have time, I will want to get into a couple of things, a couple of reports that a leading consulting firm called IMS Quintiles has put out recently, which would address also some of these points, which we can come back to.
Tim.
Well, the overwhelming majority of my clients are on flat dollar copays rather than percentage copays. But you're right, that's a problem in the industry, that the intention of high deductible plans and co-insurances were to take the shield away from the member and give them the opportunity to at least get some glimpse into what the true cost of the drug was. And that's still achievable even in a flat dollar copay system. And we take great pains as an industry to provide that level of education and information to the member, because it's very important to our clients that they understand, that the members understand what the true cost of the drug is, not just a $5 or a $10 or $20 copay.
I'm old enough to remember the first pharmacy card programs coming out where there were zero copays for many of the drugs, and geez, unbelievable if you had to pay $5 for a particular script being issued. We have seen the introduction of different, and much higher deductibles, co-insurances, co-pays. We have under the Affordable Care Act, we have, a very high out-of-pocket cost that has to be absorbed by individuals associated with this. How do you make this transparent to the consumer? How do you empower the individual patient consumer, and there is a little bit of difference, I agree with Sarah, understand what their choices are? And I'll take it one step further. It's also very complicated because when they go into the physician's office, the physician may be dealing with 10 different carriers, and that may be light compared to the total number of carriers. Each one has their own formula, each one has their own pricing, each patient has their own benefit design and cost sharing. How can we empower the consumer and the others that are involved in the writing and of course paying for the script?
It's all about education and transparency, and it has to be a multi-channel approach that most PBMs take, which is member portals, apps on smartphones, targeted mailings, and interventions. That's really the way to do it, is just to be as transparent as possible to the end user and to the member. It's very difficult for the physician, I agree, and PBMs I don't think do as good a job as they could. Maybe more so on the health plan side than they do on the standalone PBM model, communicating with physicians because of you're right, I mean, there's just so many PBMs that they have to interact with and so many formularies.
It's a complaint we hear from providers all the time, we can't possibly understand it, that type of deal. Anything from the Cigna side?
I'd add a couple things. Just on plan design, it's very important to maintain the ability to offer up different plan design options. One size does not fit all, right? Because with one size, I'll describe it as an average, right? With an average, you got outliers this way, you got outliers that way. It really doesn't meet the needs of the whole population. So maintaining the ability to offer up choice for individuals and for plan sponsors, an employer, a union, on what best meets the needs of their population is extremely important, because we do have different clients that have different philosophies around things. Is it a catastrophic benefit? Is it a benefit that, hey, we want to do everything, have no costs to keep people at their desks, right? I mean, the full gamut. So that choice is incredibly important. And then the balance really comes in as it relates to the consumerism. What's the right balance where we're protecting the consumer or the patient or the member, right? So that they can afford their medications, but it advances awareness around what they cost, what the options are. So he or she can engage with their physician on the different choices that may exist, right? And that's part of the role that we try to play, is to A, create that awareness, B, take a lot of the tools both with the consumer but also with the physician to understand what the alternatives are, to understand what the cost differences are, to figure out what is the best path. Because each of us as individuals, we make different decisions for different reasons at different points in path. And that's a key component of it. I'd say with it also, aside from aligning some of the incentives and the tools with the consumer, it's very, very important to continue to advance the alignment, the financial alignment with physicians. And this is something that Cigna is very committed to, including bringing in the cost of drug therapy into that. Because we talk about stats of prescription drug in the commercial base. This year, actually next year, the cost of prescription drugs, when you add up all the costs under the pharmacy benefit and under the medical benefit, will be the largest service category of all healthcare costs. It will exceed inpatient hospitalization costs for the first time. So we're trying to align what we do with pharma. We're trying to align what we do with the PBM. We're trying to align what we're doing with the physician on his or her choices, right, that drives the best care and affordability. And you have to do that when something now represents $1 out of $5 and is going to continue to grow as a percentage for years and years to come. So it really is alignment. A lot of the challenges, I think a lot of the misconceptions that also exist in the industry around where does the financial alignment on reimbursement up and down and across the food chain, if you will, that we need to clear up. And where there is misalignment, let's call a spade and figure out how to bring it into alignment.
You should call a spade a spade. I mean, when you're looking at the categories we're talking about, let's say it's the largest category of spend that you would have. Then you say it's larger than inpatient spending. So you're separating out hospital inpatient, hospital outpatient, any other buckets with that hospital spend, because the discussion here has been the ingredient cost of brand medications. So that prescription drug spend would include the spending on brands plus the spending on generics. So if you're looking at this, if you're going to bifurcate out different categories to say that this category, that the drug spend is greater than one of the categories that you would have, then I would think it would also be logical to bifurcate out the prescription drug category, to say that this is brand spending versus generic spending. So, and you look at that part, you're talking about substantially less. Now, 1 in 5 of the healthcare dollar within about 18%, I would abide by that for the commercial line of business. It's less than that when you look at the overall marketplace. But one thing also to keep in mind is that when you're talking about also inpatient spending, you're talking about how much you're spending in the aggregate. That trend line, I was looking at this the other day. You know, over the next 10 years, between 2016 and 2025, healthcare spending, according to the federal government, according to CMS, is expected to rise by $2.4 trillion, overall healthcare spending. What the federal government says, combined, and so for all drugs, retail drugs and physician and hospital administered drugs, they will account for 16% of that increase, the $2.4 trillion. Everything else accounts for the other 84% is all other stuff within the healthcare space. So drugs are accounting for 16% of that overall tide. So 5 times as much was going to be for other things within the healthcare systems. Just the spending on hospitals and physicians alone over the next 10 years, the cumulative spending on hospitals and physicians alone is nearly $1 trillion more than what the growth in spending is expected to be, cumulative growth in spending expected to be for prescription drugs. This category in no way mathematically is driving the overall healthcare spending growth. It is a factor in healthcare spending growth, but it's not the overall driver once you take out all rebates and discounts that manufacturers that are paying into the supply chain. And I don't want to talk too long because I just want to make just a last. Well, I'll save it.
Oh, please.
All right. IMS Quintiles put out a couple of recent reports. I hope you guys have seen. If you haven't, you should look at them on their website. They put out a report on Medicare Part D rebates. A lot of stuff you talked about was that there's no rebating or negotiation in Medicare. There's robust negotiation in Medicare. They put out a report there. But in that report was a very interesting graph at the beginning, which talked about not just Medicare Part D, but all products and all payers. So across all lines of business for all products, they said that manufacturers keep 62% of the list price of a drug. So 38% of the list price of a drug is given in rebates, discounts, price concessions through the overall supply chain, to the pharmaceutical supply chain. They said that patients pay about 22% of the list price of a drug. And the remaining 40, so 38 plus 22, you're at 60% right now. So the remaining 40% is what payers pay, what the insurers pay. So the insurers pay less the rebates and discounts that manufacturers provide, and they pay less the patient cost share amount. Because when a PBM pays a pharmacy, they're paying them an amount less than minus what the patient cost share would be for that particular product. They're charged for 40%. So that's their cost exposure of the list price of drugs. So when we talk about this debate, yes, net prices are not public, list prices are. But what you're talking about is how can 40% of the list price be a driver? And also one more report that IMS had put out looked at brand price growth over time since 2011 through 2015. They said in 2015, list prices were invoice price, which is similar to list price, grew by 12.4%. So you're like, wow, double-digit growth. That's tough. But when you take out all the rebates and discounts that manufacturers gave, the net price growth was 2.8% in 2015. And that's been published in their Use of Medicines report, which came out in April of this year.
I think one of the important aspects of what you're saying, and I think this ties to really the conversation today, is transparency and understanding of really what goes into it from all aspects of the pricing mechanism, as well as from the clinical side. There is a lot of attention, and I think everybody kind of recognizes that almost every day now you pick up the paper and there's a new article, whether it be the Wall Street Journal or one of the health issues. Are we starting to reach a tipping point in the United States where there's going to be more and more pressure for state and federal regulation? And do you think this is something that should be coming? Tim, I'll start with you on that.
I'm not a fan of regulation, but I am a fan of transparency. So the more reporting requirements, the more exposure to cost structures, both on the manufacturer side and on the PBM side, and all across the board, I think is a good thing. Sunshine's a beautiful thing and solves a lot of problems, I think.
Yeah, the way we kind of look at regulation is regulation occurs when there's a problem that's not being solved. And the problem is big enough that it needs to be solved. And then regulation occurs. And sometimes there's great regulation, sometimes there's bad regulation, sometimes there's good regulation with unintended consequence. So putting us on a better path to affordability, and really I'll call it engineering out the waste, and I'm defining that pretty liberally, is critically important, because there are some wonderful advancements in medicine that are coming and the drugs that are coming, and we need to be in a better position to afford them. And if there are opportunities to bring better alignment on reimbursement all through the food chain, all through the delivery system, that can free up dollars today, we need to take advantage of it, right? Because there is a wave that is building with wonderful advancements in innovation that is going to come with a healthy price tag, right? And we need to be able to afford that. Otherwise, we are going to pay the penalty, we being individuals, ourselves, our family members, and others, where some hard choices are going to need to be made in the future. So, as we think about regulation, a lot of what we start with in our dialogue is what are the things that we're trying to solve? let's agree upon the problem. Let's not use averages. Let's not use the 2% overall as an example, because there are areas where the prices come down dramatically. That's fantastic, right? Hidden within there are areas it's going in the absolute opposite direction. So how do we focus this dialogue on those areas that need our collective attention, and then really figure out how do we advance this in a very aligned way, right, that gets medicines to the individuals that need them in a way that they're going to be able to reap the benefit, right, and they and the plan sponsors, being the employers, the unions, the governments, are going to be able to afford today and tomorrow. And we welcome that dialogue.
Yep.
Thank you, and I'll give you an opportunity for a quick response. I want to
Sure.
make sure we have enough time to take some of the questions that we have today. Is the pharma industry recognizing that there's more and more pressure on that, and are there discussions to maybe do some self-regulation in regards to?
Absolutely, and the point that I want to make is that we believe in private negotiation. We think it's a better system than government price controls. That's for one. We don't believe in that. We also think we should be protecting the patient more, and we should be and also paying for value is a very good concept that needs to be further explored. But there's a couple of things from a regulation perspective the government can do to really help, like a value-based contract we talked about here. So the general concept of that is, okay, the provider, so the insurer and the manufacturer agree to a clinical endpoint that the patient has to meet. Like say if it's diabetes, that their A1C has to be within a particular range for that drug to be reimbursed at a particular level that they negotiate. Now, if for whatever reason the patient does not meet that clinical endpoint, then the value-based contract arrangement is that the manufacturer would refund monies back to the payer. Okay? But for that to work, the government needs to change. There's a few laws and regulations that need to be changed. One is the Medicaid best price regulation. Medicaid best price states that a single commercial sale will set the net price that has to be paid to every single Medicaid plan. So if you have one drug for one person, because they're physiologically a little bit, they have a different health condition, the drug didn't work for them, then you just set the new net price at zero, essentially, for everybody in the whole country, for Medicaid plans. There's things like that the government could really do to help get out of the way, to help foster additional negotiation for more value-based type agreements to come into play, which would be helpful. And one more thing about that part, which is my own pet peeve, which is not a pharma position, but it's my position, that you have to protect the patient a lot more than this. Even in those agreements, there's a health economics conference in Washington, D.C., the ISPOR conference this past summer, and they had a bunch of folks. United was one of the groups up there, so I asked a question. I didn't tell them who I was, but I couldn't help myself. So I said, all right, so say you have a situation in a high deductible plan, patient pays a good bit of money, drug didn't work for them, the manufacturer returns money back to the insurer. But the patient put out a lot of money. They put out a lot of money there. Are you going to return what the patient put out back to the patient? And the current agreements don't have that provision. The person from United said no. It's like, no, we're not going to return that. So wait a minute. The patient paid their deductible portion, or maybe they hit their out-of-pocket max, or they had a co-insurance, and their cost share was out there, so they're not going to be made whole. But the insurer would be made whole in that agreement. So we're all for it, but these things need work, and they need some time to work themselves out so that it's equitable for everybody in the marketplace.
Excellent question. I'd like to turn this over now for questions from the audience, and I'll hand this over to Don.
Thank you, Michael. There have been a lot of nice questions here that I think can take another hour or so, but I'm going to cut to some that I think might be most useful. One question comes and asks, I'd like to ask Tim and Chris if they would challenge Saumil's suggestion that the appropriate starting point for price negotiation on new drugs is the cost to treat the condition absent the drug. Is there not a more appropriate value-based method for this?
Go ahead.
Very good.
It's the model that we work in. I don't know. I don't disagree with that premise that the replacement value is a good starting point. It's an aspect of it. I think the R&D and your SG&A also has to be factored into it as well. But I don't disagree with that as a starting point.
Yeah, what I would add to it, I mean, many things do and should go into pricing the medication. One of the challenges that I'd say we have today is that the cost of the current therapies in the class are often used as the benchmark or a heavy consideration, right? Not the only, but a heavy consideration in what that new therapy should cost, right? What we're seeing in some categories, not all, is that based upon the value that those drugs are delivering, there needs to be a fundamental reset in the existing therapies. So if you're always comparing to what exists today, and the value through some real rigorous analysis is 10, 20, 30, whatever percent higher, and you're pricing off of that versus starting from here, there's an immediate disconnect. And part of the challenge in some categories, not all, right, is those drugs started years and years ago at a reasonable place. And then if you have double-digit price inflation over 5, 6, 7, 8 years, right, the clinical value of the drug has not changed. The price has doubled, right? And that price is doubling net of all the rebates, it's net of everything. And then a new drug comes in, and that's the benchmark. Are you really aligning it to the fundamental value? And that's one of the things that we're grappling with, right? So it's not just day one, what's an appropriate price for a new drug, but it's also a year out, 2 years out, 5 years out. And depending upon the speed of innovation, some things are on a good path, some things there's some fundamental reset that needs to occur in that regard. And the one thing that will truly, truly help in all these categories are things that we can do collectively to bring more competition to the table. Because competition, I said it earlier, it works, right? It will drive better innovation. It will drive faster innovation, right? It will drive better pricing for everybody in the healthcare delivery system. Customer, employer, you name it. And there are things that we need to do collectively in order to make sure that we eliminate some of those barriers, because that does drive, in some cases, some fundamental resets that need to occur.
The subject of rebates seems to have hit a nerve. There's been 3 or 4 questions about rebates. I'm going to list a couple of the questions, and feel free to talk about them. What's the difference between a rebate and a bribe? What are the criteria for rebates? What rebate amount returns to the plan / employer / consumer? Do the payers need to remove the rebates on drugs from the MLR as used in the ACA 80-20 rules?
That's a lot of questions.
A lot of questions.
That are in there. I mean, I'll start. I mean, think of a rebate as an additional discount.
That's all it is.
Right? It's then how these rebate dollars are used in decision making, and how they're used in terms of aligning the financial interests as the plan sponsor, being the employer, the union, the government, want those used. I mean, we have the ability as a PBM, and we make a modest margin, and we can make it in different places, right? We have a lot of agreements where 100% of the rebates are passed back to the plan sponsor, to the employer and the union. So a lot of it with the rebates is it's an additional discount, and then you go into two prongs with it. How do you use that in your decision making? And then how do you align where and how you make money as a PBM with the underlying plan sponsor? And those are the dialogues and the discussions that I'd say are are least understood in many aspects, but they're critical conversations that need to occur, and they do occur. I'll give you some examples. And for the formulary changes that are going on for 1/1/17 across the industry, there are some major differences on how rebate dollars are being used. All right, I won't use specific drug examples. You can reach different conclusions on what drugs to decide to cover and what drugs you do not decide to cover, right? Falling into clinically equivalent in your choices, depending upon your formulary strategy and how you do your math. And there are many examples where we can point to and others can point to where you're eliminating the drug that provides you the highest rebate from your formulary and not covering it because there is a far lower cost and equally effective set of other drugs that drive a lower net cost. Actually, I will give you 2 examples, right, because it's all public. Last year, Glumetza, an oral diabetes drug, right, call it list price $5,000, $6,000. The generic form of it, ballpark $100. Depending upon how you do your math, you reach a different conclusion. We excluded Glumetza, right? And today, for that category, less than 1 or 2% of the population for that drug get that form versus the generic form. And when you do that math, the plan sponsor, right, saves $4,000 or $5,000 in that regard. Another good example for 1117 that you've probably seen advertised a ton is the drug Jublia, right, for toe fungus. Heavily advertised, heavily couponed, heavily detailed with physicians. Call it $700-ish, right, before the rebate. The alternatives that do a comparable job, it's less than $100, call it $40 to $50 in that regard. If a company were to endorse a rebate maximization strategy, you'd probably keep Jublia on your formulary, right? We follow a low net cost strategy in that category. 1117 Jublia is not covered, right? Because if you want to get to a suite of alternatives and get to the lowest net drug cost, not on a % discount, not on a rebate guarantee per brand script, but on a dollar amount which you as an individual, you as the plan sponsor pay, right? You have to do the math a certain way, right? And we are, both as Cigna as a health plan and as a PBM, we have a self-insured book of business, we have a large fully insured book of business. And so at least for our model, we've oriented our model around how do you get to the lowest net drug cost? Because when we say we spend our clients' money as if it's our own, well, when you have a fully insured book of business, it is your own, right? And you are going at risk. And these are the nuances around rebates, I think, that are often misunderstood in that, because they are discounts. We want to garner significant, in the way that the health pricing is done in the payment today, significant rebates. It's a question of what do you do with the rebate dollars and how do you use them in your decision making.
Yeah, we in our model pass back 100% of the rebates that we get from manufacturers to our clients, at least in the self-insured commercial side. And what concerns me, I mean, I agree, those are the conversations that happen kind of behind the scenes with our clients that most people aren't aware of, the calculus that we go through to decide which drugs are on formulary and which are not, and how the rebate impacts that. My concern, I think all of us would share it, is that the member kind of gets lost in the shuffle. He gets whipsawed, right, with restricted formularies. It's on 1 year, it's off the next, it's on 6 months. And those are the pieces that have to be ameliorated from the plan sponsor's perspective, that have a focus on member disruption. So there'll be a lot of numbers thrown out in terms of huge rebates that are available, but when push comes to shove, the plan sponsors are frequently reluctant to pull the trigger on that because of the impact that it has on members.
Now, all right, so the rebates from 2011 to 12 to now, they've grown exponentially. There's been a lot more rebating. So the gap between list and net prices has grown. This same approach in an environment where patients are increasingly exposed to the list price of a drug based upon benefit design changes has to change. Not through government action, but has to from a market development perspective. We have to find a way to insulate the patient from this. So in a situation where you're talking, so rebates have grown, and rebates are paid on a percent of the list price of a drug. Admin fees that manufacturers pay to PBMs are also typically on a percent of the list price of a drug. That's grown as well. So these things over time, what you are seeing tied to the list price of the drug, that dynamic cannot be continued. Now manufacturers pay rebates to PBMs and they accept them to be able to garner formulary position for their products. I wouldn't call it a bribe. It's just a negotiation. It's a negotiation that you would have. It's a private negotiation. The system has worked well, pretty well for a good while. But the question now is that because of the benefit design changes we talked about, the patients are getting exposed to the list price they were never really intended to get fully exposed to. And that could be the main impetus to try to develop a slightly alternate model to how we handle reimbursement through the supply chain.